All right, calcitonin, you first learned about it when you were studying the skeletal system way back in chapter 17. And so keep in mind, we're going to go into a little bit more detail here when we're talking about what calcitonin does and the effects that it has here in the endocrine system there. So if you recall, calcitonin is that hormone, right? That, like I said, the name of it kind of implies what it does. It's going to put calcium into tissues. And in this case, what is going to cause that, the stimulus for calcitonin releases, is it up there? It is, darn it. All right. The stimulus is when you're hypercalcemic, when you have too much calcium floating around in your blood. And so you have special receptors in your parafollicular cells there, right? And they're going to identify that high calcium level. And so what they'll do is they'll stimulate production of, all right, our calcitonin. And so calcitonin is going to then circulate throughout, like any other hormone does. It's going to circulate throughout the circulatory system looking for its target cells. And it's going to find some in your bones, specifically the osteoclasts. You all remember what do osteoclasts do? Is it up there? No, it's not. What do? Yeah, clasts are going to tear down. How I taught my 210 sections is osteoblast B, build bone. Okay, osteoblast build, osteoclasts like to tear it down. So we're going to shut off their ability to do that. So we're going to inhibit the osteoclast. And then at the same time, remember, we lose most of our solutes through filtration in the kidneys. So we're going to affect our kidneys. We're going to tell the kidneys, all right, what you need to do is our blood calcium levels are too high. You're going to increase the excretion of calcium through urine. And so we're going to increase or stimulate, all right, the kidneys to get rid of calcium. Does that make sense to y'all? Not too bad. All right, so calcitonin is not a really terribly difficult cell to understand there. All right, so let's kind of move on here. This slide should look familiar to everybody because we covered it in lab class last week. And this is the adrenal glands. And so those are those glands that sit on the superior pole of the kidneys. And so we have two kidneys, and so therefore you have two adrenal glands, also known as suprarenal glands. And so you're going to see with the kidneys later on in this semester, the kidneys have kind of like an outer layer and an inner layer, cortex and a medulla. Same thing with the kidneys. The adrenal glands. The adrenal glands have a capsule. Y'all remember? Let's see. We'll test your memories. When usually a structure, an organ, some tissue is covered by what they call a fibrous capsule or a capsule in general. Do you all remember I said it once, what the actual connective tissue that typically makes up the capsule? So, I'm sorry? Dense or regular. Yep. It's pretty, I hate to say it by exclusion, but dense regular connective tissue is pretty much in tendons and ligaments and a couple other places, but that's pretty much it. So if you have to guess, go with dense or regular because that's found almost anywhere. That's actually the number one of the most abundant connective tissue in the dermis, the thick layer of the deeper layer of your skin. Okay. So back to the adrenal glands. So you have an outer layer and an inner layer. The inner layer is the adrenal medulla. And I kind of feel like everybody kind of should be familiar with this. That's the layer that is going to release the adrenaline or the epinephrine and the norepinephrine. And it's the neurosecretory cells that will do that. And what stimulates those neurosecretory cells? Nervous system activity. Yeah, your sympathetic system will tell the neurosecretory cells, release the norepinephrine and the epinephrine, and therefore it will do so. Because remember, that was that one lower motor neuron, all right? That is one single neuron that goes from the spinal cord all the way out to the adrenal medulla, decreasing synapses. The more synapses you have, the slower your signal is going to be. Well, when we're releasing adrenaline, epinephrine and norepinephrine, it could be an emergency situation. We don't have time to waste. So we want to do it quick and easy with as few delays as possible. Bam. That's what we're going to get here with our lower motor neuron in the neurosecretory cells there. Okay. So that's the adrenal medulla. Keep that in mind. All right. The next one is the adrenal cortex. The adrenal cortex, this is the one that is going to be, all right, producing those corticosteroids there. And of course, what is going to, the important ingredient that makes a hormone, a steroid, is cholesterol. You're going to have a cholesterol as your precursor to build out these hormones here. And so therefore, cholesterol is a lipid. So we want to keep a lot of lipids on hand. So this layer will have that yellowish kind of orangish appearance to it, primarily because lipids appear more yellowish there. And so there's 3 layers that we learned about in lab class last week, all right? GFR, all right, the zona glomerulosa, zona fasciculata, and then the zona fascicularis. And so those are our 3 layers that we're going to kind of review here, right? So here you can see a nice gross dissection, all right, of where, of the kidneys here and the relation of where the adrenal gland sits right on top, superiorly, right above the kidney there. And this slide here is showing you all those layers through the capsule, through the cortex, and down into the medulla there. And you'll see the 3 layers of the cortex here, the 3 zonas there, glomerulosa, fasciculata, and then the reticularis, which we're going to talk about. So this is a little bit of a review, but I promise you, really kind of just learn the examples that we're giving you. All right. For example, aldosterone. We're going to talk a lot about that later on when we talk about fluid balance. But for right now, aldosterone is a mineral corticoid, all right? And minerals, start thinking of certain electrolytes like magnesium, calcium, phosphate, sodium, all of those, all right? So this is going to regulate, all right, your sodium and potassium levels there. All right, so basically it's going to retain sodium. And again, usually when I'm teaching my 10 classes and I'm talking about sodium and potassium, I talk about how a solute, because that's what sodium and potassium are considered when we're dealing with fluids and whatnot in solutions. And what's the big deal about sodium? What do doctors tell patients that have high blood pressure to monitor about their sodium levels? What do they usually say? Lower it. Yeah, monitor it, right? Why? What does sodium have to do with anything? What'd you say? Yes, exactly. Water is a follower, all right? I want you to learn that, okay? Because we'll talk about it when we get into diabetes here in a little bit. But water follows solutes. That's what we discussed when you kind of learned about osmosis, right? Osmosis is the movement of water from an area of high water concentration to an area of low water concentration. But also, water is going to move towards solutes. Remember, we talked about tonicity, that pressure, right? That is going to move water from one area to another, right? If you don't recall that, don't worry. We will go into that in a little bit more detail when we talk about fluid balance and all that. But what I want you to know is right now is water follows solutes, sodium especially. So if you think about it, you guys can reason this through. If you think about it, when you're increasing your diet with sodium, the sodium is eventually going to wind up into your bloodstream, right? Eventually, it'll wind up in cells and other tissues, right? But if you're having a lot of sodium in your diet, you're going to increase the sodium levels in your bloodstream. What did we just say? What is water going to do? It's going to go towards where the sodium is. That means it's going to go into your bloodstream. What's it going to do to your fluid volume in your bloodstream? Increase it. And what did I say? When you increase blood volume, what do? Increase blood pressure. Kind of see where we're going with? Kind of see where the doctors are talking about? Lower your sodium levels, because then you won't retain water in your bloodstream where the high sodium levels are going to be located, right? Well, and as we go through this course, you're going to understand that to a better degree, but I just wanted to throw that out there to you. All right, anyways, so here's what I want you to know about aldosterone. It retains sodium and it kicks out or gets rid of potassium. And in fact, the number 1 influencer of your aldosterone secretion is not sodium levels, not water levels, it's actually potassium. So if you have high potassium levels in your blood, right, you are going to produce aldosterone to lower potassium. Because remember, too much potassium, what can that do to us? Sam, what do you think?
Probably harms your neuron.
Yeah, it's going to kill you. Yeah, remember? Because I mean, it will stop your heart. All right, there'll be issues there. So keep that in consideration. That's why the biggest influence over aldosterone, all right, secretion is potassium levels. All right, but it plays a strong role in our fluid balance, or what we consider that regulation of the electrolyte levels. Because if you're regulating the electrolyte levels in an indirect way, you're going to be influencing water. Right? Didn't we just say that? Okay, water's a follower. It's going to follow sodium. It's going to follow certain solutes. We all know what it does with glucose, right? what is one of the complaints that a person with diabetes has? What are they doing all the time? What are they doing? Well, they're drinking, but what happens when you drink too much? You pee a lot. They're always peeing, right? So they're always peeing. And the reason why is, right, what are you going to find if I do a dipstick test, a urinalysis test on a patient, and I'm looking for something in the urine in a diabetic patient? What am I going to find? Sugar, glucose, right? Glucose is a solute. And guess what water likes to do? If you're peeing out the glucose, you're peeing out the water because the water follows glucose. More on that later. All right. See, I should be like one of those people that announces, like movie trailers, just wait until next week, on our show. All right. So glucocorticoids is the next, all right, class of steroids that we're going to be discussing. And these have to do with another type of regulation, but in this case, your blood sugar levels, right? Blood sugar levels. So if you have, all right, decreased blood sugar levels, these hormones or these glucocorticoids are going to stimulate to increase those blood sugar levels. And there's our famous hormone, the stress hormone, cortisol. So many people are in constant production of cortisol. I guarantee you probably about 1/4 of us sitting in here have elevated cortisol levels for one reason or another. It's true. It's just what happens. I mean, we're designed to respond to stimuli, as you know, because we're studying it. And I guarantee you, especially in stressful situations like school, all right? So that's what we're looking at. So cortisol is going to increase the blood sugar level, okay? What else did we learn so far that increases blood sugar levels, right? Thyroid hormone, right? That's going to increase. What else did we learn? Glucagon we haven't learned it technically, but yeah, we talked about it. That's fine. What's the other one? What's the other hormone that we talked about last week? Makes us taller. Growth hormone. Yeah, growth hormone. So we're learning about all these hormones that are going to help increase our blood sugar level. So cortisol is one of them. And this is formed in the middle layer in the zona fasciculata. And then finally, our last class of hormones that we're going to be talking about are the gonadocorticoids, right? So think gonads, right? So think of the sex hormones. Now, here's the thing. This layer is going to only produce androgens, male sex hormones. Not a problem, ladies, because guess what? You have specialized tissues and cells that are just going to go one extra step and convert those androgens into estrogen and progesterone. That's all it is. All right. So if you're XX, you just have that one extra step to convert the androgens into estrogen. All right. XY, no problem. We're making the androgens as is. So keep that in mind. Androgens, those are the male sex hormones, no problem. We're going to convert that over into estrogen in ladies and men. We don't have to worry about it. But at the same time, okay, you're going to produce a small amount of your sex hormones in your kidneys. Obviously, the majority is going to come from the primary reproductive organs, right? Ladies, and for you, it's the ovaries, and men, for you, it's going to be the testes, okay? Or I should say for us. I'm speaking for me too. All right. So let's talk about cortisol, right? The stress hormone and what's going to cause its release. Again, we're basing this off of a reflex. So stimulus, receptor, control center, effector. And a lot of these stimuli are based on negative feedback. So if levels get too high, those high levels will then start to inhibit the release, all right, of the hormone. And we'll talk about that here in a second. Okay, so when we're dealing here with cortisol, the overall effect is to increase nutrient levels in the blood. Folks, we've seen this already. In thyroxine, we saw it with growth hormone. When you increase nutrient levels in the blood, you could probably, I don't even have to put it up there. I don't know if it's even on the screen here. We can probably already figure out what it's going to do. It's going to start releasing glucose from certain tissues. All right, that's going to be the liver. So we're going to start breaking down the glycogen. So glycogenolysis, gluconeogenesis. All right, so certain things are going to start to be stimulated to increase those nutrient levels. Because think about it, you're in a stressful situation. Something's happening. Let's say you're being mauled by a tiger, or let's not even go that far. Let's say you're being chased by the tiger. It hasn't gotten you yet, right? You need nutrients, right? Flowing through your blood. Those nutrients, i.e., glucose, are going to be converted into ATP, energy, to get you the heck out of danger. So that's what we want to do. We want to release all of that into our bloodstream so the tissues that need it, most likely the skeletal muscles, have an abundance of it. So you can protect yourself in that situation when the tiger is chasing you. We don't want to, do the opposite. We don't want to take, all right, the sugar out of your blood. right? We don't want to make you hypoglycemic, have you pass out, and then the tiger's going to be taking you apart bit by bit. All right, so here are what we're looking at when we're talking about our cortisol release is this regulation system here. The hypothalamic, which is the hypothalamus, pituitary, adrenal axis. Right, so you notice the first two terms here, hypothalamic has to do with with the hypothalamus, and then our anterior pituitary, and then our third location, the adrenal glands there. And look at all of those different stimuli. Who doesn't fit that profile? Stress, all right? Late stages of sleep. I mean, that's the thing. I mean, who gets enough sleep here, right? And so in this case, you can see the big one here is stress. That's why we nickname it the stress hormone, right? So you're going to see a release of cortisol, right, in situations when you're under physical stress, mental or emotional stress. So we'll see that's a huge stimulator for that. And then at the end, I think I've got a graph on this slideshow here that shows cortisol being released later on, in the hours just before you wake. Because again, when you're sleeping, hopefully some of you recall when we learned about sleep back in chapter 13, learned about the brain, one of the big purposes for sleep is rest and digest, but we can repair damaged tissue, grow tissue. That's why babies sleep all the time, because they're growing and they're maintaining and building new tissue. And so that's why our cortisol levels spike near the end, because we want to release a lot of those nutrients so we can take those nutrients and start to build and repair damaged tissue or help to make new tissue as we're growing. All right. So keep that in mind. We'll go through all these different not symptoms, but stimuli here. All right. So of course, we're going to see our chorionic releasing hormone which is traveling to the anterior pituitary, and it causes it to. Did you have a question? Yeah. Okay. And then that's going to cause the anterior pituitary to release our ACTH. And then eventually ACTH will travel down to the adrenal cortex, and it'll release cortisol and the corticosteroid. Question?
Yes. Okay. So it says cortisol increases nutrient levels in the blood. I'm a little confused. I was doing the quiz this weekend.
Yep.
And one of the questions, it was like blank, glucose uptake and protein tablets. The question said it decreases glucose.
Yeah, we're gonna talk. Yeah. We'll talk. We'll talk. Yeah. It's all good. No, it's all good. I'm glad you're reading, you're thinking. I love it. All right. So again, we have another situation in which we have a hormone that's going to be traveling through the bloodstream on our carrier proteins. And what do carrier proteins do? Well, they transport it, but remember, they're there to maintain and make sure that that hormone doesn't degrade, right? So it doesn't decrease its half-life. Okay, so keep that in mind. That's the importance of those carrier proteins here, right? And of course, right, just like we've seen before, this hormone, right, stimulation is regulated through negative feedback, right? When we have too much cortisol, we're going to start decreasing its output, right, through the negative feedback loop, which we'll talk about here. All right. Here's one of our famous pictures here. So we'll start off up here at the top, right, on our reflex here. Starting off, any reflex is a stimulus. And so you can see, all right, now granted, stress is listed here at the bottom, right? But again, blood levels of cortisol, the time of day, and then stress. Those are going to be the three things that are going to be primarily, all right, the main causes for cortisol release. Same type of scenario here, right? So we have our hypothalamus here, which is going to be releasing the corticotropin, all right, releasing hormone, CRH, into the anterior pituitary. Anterior pituitary is going to release the ACTH, the adrenal corticotropic hormone, all right, through the bloodstream, makes its way down here into our adrenal glands, and then it causes the adrenal glands to release cortisol or corticosteroid, right, into the bloodstream here. And so it floats around the body. Right? And so you'll see here, when we get to the effectors here in the liver, right, we're going to increase our glycogenolysis and the gluconeogenesis, right, because we want to increase nutrient levels, and therefore we're going to decrease glycogenesis. We're not going to be taking stuff back off the truck, right? Or we're not going to be putting stuff back on the truck as we take it off. Right. Same thing here when we're looking at the adipose connective tissues, same type of scenario. Increase lipolysis, right? We're going to start to release triglycerides into our bloodstream, and we're going to decrease lipogenesis here. All right, so now what we're looking at here for all the cells, and this might help to answer your question here, right? Now we're going to look at protein catabolism. What does that mean? Is it up there? Good, it's not up there. Break it down. Protein catabolism. Well, catabolism is a form of metabolism, right? But which version breaks it down? That's right. So if we're going to break proteins down, what are we going to break them down into? Amino acids, right? The building blocks. Guess what? We can use those amino acids in gluconeogenesis, or we can use them for other things, right? So consider those amino acids, right? Those are nutrient building blocks. For whatever reason, we might want to make proteins somewhere else, right? Depending on what's going to be utilized. But at the same time, the more amino acids you have, and if you have gluconeogenesis rolling forward in full effect, you're just going to be feeding those amino acids into gluconeogenesis so we can make more glucose for whatever reason. All right. And at the same time, the cells here are going to decrease their glucose intake, right? Depending on, remember, supply and demand, y'all. Supply and demand. Certain cells, like your skeletal muscle cells, in our example, when you're being chased by the tiger, they're going to be taking in, all right, glucose because they need it to make ATP, right? If you recall, remember the different ATP metabolism pathways that you have? There was 3 of them. Okay, you have the on-hand ones, which is the creatine kinase and the myoglobin, and then you would have the aerobic cellular respiration and then glycolysis. We'll talk about all those in more detail, but you will run through your stored sugar levels in skeletal muscle relatively quick. Because remember, there's 2 places where you can store glycogen, in the liver and in skeletal muscle, right? So we're going to run through those stored glycogen levels relatively fast. So that means that we need to have more glucose on hand in your blood so we can absorb it into the cells and utilize it and metabolize that. All right, we'll talk about what happens here with high levels of cortisol. Believe you me, I'm sure that some of you have seen folks that have had these high levels of cortisol, and I'll talk to you about it. Anybody that's on long-term steroids, glucosteroids, you see it all the time. They get that puffy face and whatnot, and it's what it says right up there. They maintain the increased sodium retention, increases that water absorption, and so they'll have more water. We'll talk about some of these here in a second. Here is that graph I was telling you about here. You'll notice, all right, if you're looking at sleep hours roughly, okay, you'll notice near the latter part of that sleep cycle, you're releasing a significant amount of cortisol, right? And then when you wake up, and of course, this is based on 8 hours, it varies from person to person. And then as the day goes on, your cortisol levels kind of drift away, all right? So keep that in mind. So this is, again, another reason why it's important to get enough sleep. I know we never do. All right. Yes, ma'am.
But if you're gonna do caffeine in the morning, it says not to drink it for like at least an hour and a half, something like that. You would almost be good.
Yeah, I mean, I could see the caffeine. I don't know the actual definite effects.
And they will end up feeling more tired.
Has anyone ever tried that? Not drinking coffee? I try not to drink it at least until an hour or 2 after I've been awake. Doesn't always work, all right? But yeah, I mean, I think for me, it's a psychological thing. Like, I didn't have any coffee. That's a lie. I had a cup of coffee before I came to class, but I didn't have any this morning, and I didn't feel exhausted and whatnot. And I didn't does anyone here ever get caffeine withdrawal headaches?
Oh,
Yeah. Yeah. So if you ever try to give up caffeine, you got to prepare. I knew a guy that used to drink 1 to 2-liter bottles of Mountain Dew every day. And he was just like what you all are doing, studying, and he was in school, and he decided he decided to stop before exams. I'm like, dude, why don't you wait until the exams are over with? He would always come in with complaints about his headaches. But I have not heard about the caffeine and the cortisol, but I could see that because I couldn't tell you the actual mechanism. I'll have to look into that though. Thank you. All right, and then of course we see this guy mopping his face. And again, it says cortisol level is increased by stress. And stress can be a broad term. Remember I said there's physical stress and then there's mental and emotional stress. Physical stress is like when you're exercising, you're working. Like in this picture here, that's from the textbook, and that's just the guy's actually chopping wood. And so that's what they consider the physical stress, exercise, essentially. You will release a decent amount of cortisol during the periods of when you're exercising, right? Okay, so when we're looking, again, this likes to break it down for you, and I'm a huge fan of how this breaks it down. When we're looking at the target cells here, right, keep in mind, we've seen this scenario all the way up to this point. Liver is going to be liberating stored glucose. It's going to break down glycogen, and it's going to not make the glycogen yet, right? Whereas the adipose cells, same thing. It's going to break down and release the triglycerides, the stored fats. So we can use those triglycerides through beta oxidation. We can start making ATP, all right, energy and whatnot. And then, of course, we're going to decrease or stop lipogenesis there. And then, like I said before, a lot of our cells are going to be breaking down those proteins, right, from the actual long, big protein molecule into bite-sized pieces of amino acids there. And so a lot of those amino acids go right back to the liver, and we use it to make more glucose, right? And then again, we're seeing that situation, that glucose sparing effect here. So you'll see that a lot of the cells in the body are going to, again, remember, supply and demand, folks, supply and demand. So a lot of the cells will forego their glucose uptake because they want to save it for the tissues that need it. Well, you think the brain needs it during a fight or flight kind of experience? Yes, you're darn right. Right, so the neurons get first dibs. Central nervous system gets first dibs. And then in our scenario, when you're running away from the tiger, your skeletal muscles are going to get a fair share of that, right? So they can produce and make ATP to get you the heck out of that situation there. So when you go in and you get a shot of cortisone, right? Has anyone here ever had a shot of cortisone for whatever reason? Okay. Yeah, for various things. It could be knee injury, back injury. Which was it? Your ankles? Okay, yeah. And so, again, steroids are, and again, I'm not pushing steroids, they are some of the best anti-inflammatory agents that you can give. Remember we talked about the enzyme cascade of making, remember the eicosanoids, the locally acting hormones? And I told you it starts off with arachidonic acid, that fatty acid that sits in the plasma membrane, and then it gets acted upon through these numerous enzymes to make either thromboxanes, prostaglandins, prostacyclins. All right, just kind of review that a little bit. But point being is steroids, here's AA, arachidonic acid, and it goes through its first enzymatic reaction here into, all right, there's a couple different pathways that it can go into. But point being is steroids comes in and acts right there at the source before, right, it has a chance to move into these other types of substrates there. So that's why corticosteroids, steroids in general are great for inflammation type of situations. Problem is long-term steroid use does a couple things. One, it reduces the immune system's effectiveness, right? Two, it can influence and start to cause bone thinning or osteopenia. All right, I can always tell on an x-ray if the person's age is under, like below 60 in their 50s, and if someone puts an x-ray up there and it shows bone thinning, my first question is this person on steroids? First question. And in most cases, that's the case, all right? But you have to be careful because it can suppress the immune system, and nobody wants that. Steroids are great for short term, but long term, it's a pain in the butt. Okay, so high doses, you've got to be careful because of infections in cancer. Why? Boom, suppresses the immune system. Okay, so you increase your likelihood of infection if your immune system is depreciated. So don't do it with the long-term steroids. All right, I already talked to you about, all right, the effects of sodium in water. Okay, where sodium goes, water will follow. And so cortisol, corticosteroids are going to retain sodium, therefore retain water. And that's why you'll hear people that will say someone that's on steroids has like that puffy face. Yeah, and so it's very, very common. Unfortunately, too, we talk a little bit about this when we go over the skin in chapter 6. it actually can cause issues, all right, with connective tissue repair. And so that's going to be messing up your dermis. People will complain of that are on long-term steroids that it's easy for them to bruise or cut themselves, all right, and that's because it inhibits the wound repair. All right, so you may have heard of these two conditions here: Cushing's syndrome and Addison's disease. Right, so Cushing's, you want to know the difference, right? One is too much. So Cushing's is going to be when you have too much. And a lot of times you can have Cushing's syndrome, in which, as a result of taking those steroids for a long period of time, right, they start to have all of these symptoms here. Obesity, right, because they are going to increase their adipose tissue. Hypertension. Why do you think hypertension? Increased sodium, increased fluid volume, right? So you have to be careful of that. Kidney stones, again, it's going to affect the functions of the kidney when it comes to filtration. So you have to be careful. And then especially for ladies, the menstrual irregularities. Addison's disease here. Now we're going to see what happens when you have too little. Right, and so what we'll see is mainly we'll have an issue with the glucocorticoids, right, from the zona fasciculata, and then we'll also see some issues with the mineral corticoids in the zona glomerulosa. All right, but point being is we're affecting two of those areas there. Now, here's the thing: when we're dealing with Addison's, it could be from no ACT being produced, all right, or just almost like with diabetes. Type 1, you're not producing enough insulin, right? Type 2, you can produce insulin, but your cells ignore the insulin, all right? So that's similar to what you see here. In this case, you can have no ACT being made whatsoever, or nothing is just, it's like my kids, all right? They don't respond to me when I talk to them, tell them it's time to go to bed, all right? That's what you can have as the other situation here, right? That the ACT, all right, the ACT is being produced, but the cells aren't responding to it. The target cells are like, whatever, I just want to go play my video games here, all right? So what we'll see here is weight loss, fatigue, weakness, hypotension, and then skin darkening. What can cause skin darkening? What causes skin coloration? Melanin, right? Okay, so this influences melanin. And so you'll see it increases, especially in some of these patients there. You can see it on the back of their neck in some cases, right? And in some cases, you can see it on their abdomen there. So what do we do for these folks? We give them more steroids, all right? We're going to give you lots of steroids and you'll be happy and you'll like it. Okay. So this is an interesting condition here, the adrenal genital syndrome here. And we'll see this as early as embryological, but normally you'll see it more often during the fetal development here. And so unfortunately, what happens is, in this organism, this particular person cannot make the corticosteroids. So what happens? Well, let's think about it. Negative feedback mechanism, right? If you're not producing, right, the hormone, right, then our actual anterior pituitary gland will be like, well, it's ignoring me. I just need to make more. All right. So the anterior pituitary gland makes more ACTH and it just starts pumping out tons of ACTH. Problem is, with these high levels of that ACTH, now we're going to then affect, right, a different part of the adrenal gland, and we're going to see, right, testosterone-like effects. So if you have a female fetus or embryo, an XX, all right, organism, okay, and you're influencing it with testosterone or androgen male-like characteristic, what's going to happen to that fetus? It's going to resemble more of a male appearance here. So you're going to see that newborn, right, that's going to have more masculine characteristics. And that, is anyone else like me? I can't tell if it's a boy or a girl when it's just a baby, right? I can never tell. And I always make sure that, oh, your daughter looks so pretty. Oh, that's my son. Okay, my bad. It's just hard to tell. I mean, a lot of the babies look the same to me. I mean, if they're in pink or blue or whatever, then there's an opportunity, but still, I'm so bad. Pardon? No, I know.
With this big old bow on.
Yeah.
top of it. Oh, your son, I'm like, "Cute girl,
Yeah.
cute bow."
I always just, I never try. I just don't want to have that conversation with folks. I'll just be like, oh, your child is beautiful.
Yeah. Like, oh, so cute. What is it? And it
That's
works.
perfect.
No one ever gets offended.
Yeah. Find out right away. Makes it easier that way. I actually sat down with the patient last year and talked about this. I actually busted out this slide for a patient that was undergoing a significant amount of stress in their life. And so a lot of this you'll see as we go through these different stages here, you're gonna be like, oh man, I feel like I'm in the alarm reaction stage, or I might be in the stage of resistance, and you'd be surprised. But here's what happens when we go through what we call the stress response, right? Same type of scenario. So when we're in a stressful response, the sympathetic nervous system is going to be kicked into, I don't want to say overdrive, but it's going to be active. And so we're going to see the neurosecretory cells there are going to be releasing, all right, their versions, but then we're going to be kicking in here on the adrenal gland, we're going to be releasing our cortisol. So when you're on the alarm reaction here, this is right away. Right? Say you see something horrible, like a car accident or something. It doesn't necessarily have to affect you. But that initial sight there of what you see, or if you were in a close collision on your way to class tonight, you know, and your heart rate is beating and all that, and you're like, oh my God, that's what we're seeing here. We're going to be stimulating our fight or flight division of the autonomic nervous system. First off, boom. And then our two main hormones that are going to be released are going to be epinephrine and norepinephrine. And we'll get into a lot of the effects of norepinephrine, all right, as a neurotransmitter and whatnot, but it plays a big role in the function of cardiac cells, increases contractility of the cells there. All right, so that's the alarm reaction. So again, a lot of us can go daily and deal with the alarm reaction. The stage of resistance here now, again, all this stuff that we just talked about, what cortisol does, right? It's going to be releasing nutrients into the blood, okay? So the stage of resistance here, this has been going on for quite some time. How do I know? Because it takes a little bit of time to get rid of all the glycogen that you store in your tissues, in your skeletal muscle, right? And in your liver, right? So once we've gone through, all right, all of our glycogen levels, which are stored sugar, now we got to start to figure out, okay, we've got to get some nutrients somehow. Right? So guess what? We're going to find it from other sources. You know what's one of the last resort sources for nutrients that your body will utilize? Muscle. Darn right. Yeah, it's called rhabdomyolysis. Your body will start to digest literally your own muscles. Because what are our muscles rich in? What macromolecule? We'll take a guess. You got carbohydrates, lipids, proteins, and nucleic acids. What would you say out of those four? Proteins, you nailed it. Yeah, remember actin, myosin? Right, then we have the regulatory proteins, troponin, tropomyosin, proteins. And so we're going to just tear those muscles. It's like stripping a car down and using that car, you know, those parts for parts for another vehicle. We're going to strip those proteins down out of those muscles, just break those muscles down, and we're going to start chopping up those proteins. So now we have amino acids, and we can use those amino acids for whatever we want to use. Well, guess what we're going to use those amino acids for? Gluconeogenesis. All right, we're going to use a lot of that to make energy because that's what we need to do. Remember, supply and demand, folks, supply and demand. We've got to meet those energy needs. So we'll start, once we've burnt through our glycogen, right, and we start to go into ketosis and some other function or chemical metabolism reactions in the body, rhabdomyolysis is on the list. Usually at the end, we start to tear down muscles. So we'll start using tissues that we don't necessarily want to use, right? But we have to use. And all of that is to get enough energy, all right, for whatever we need. All right, then the final one here is my patient that came in, they were in between these two last stages here, the stage of resistance and the stage of exhaustion. I feel like this person had been more so in the stage of exhaustion. So if you notice, like here, first sentence here, weeks or months, takes a while, right? So this could be going on. Some people know that this is happening, but they don't they won't do anything about it, right? But point being is this takes a while. And guess what? We've gone through fat, or most of it, and guess where we're at now? That rhabdomyolysis. We're going to start breaking down, all right, the muscles there, again, to increase our blood sugar levels, to increase our energy demands. So again, these people look, these are the type of people when you look at them, you're like, oh, you don't look good. You know, that's what you're looking at, all right, depending on how bad and run down these folks are. Because again, when you're at that stage, your body is going to have a lot of issues going on, all right, aches and pains, that sort of thing. But overall, your immune system is going to be depleted. And so if your immune system starts to go down, guess what? Now you're becoming sickly, and now you're stuck in this cycle. Now you're sick, you feel like garbage, you don't want to do anything, and you're in this stage of exhaustion. So it's a bad situation to be in. Okay. Anyways, let's get out of the adrenal glands. We're going to move into a different, all right, tissue organ, and that's going to be the pancreas. So this slide should look a little bit familiar too, because I showed you this slide to you in lab class here, right? And so just a quick review. Remember I said the pancreas is that organ that sits right in the middle of your abdomen. It's going to be a few inches above your umbilicus there. It's going to be inferior to the stomach, medial to the spleen and the duodenum, and superior to the transverse colon, just to kind of give you an idea. It sits right there in the middle. And so the spleen does a lot of different things, all right? But I told you it's one big gland. Right? And so in this semester, we get to learn about both functions of its glandum, or whatever you want to call it, right? It's both an endocrine gland and an exocrine gland. The exocrine gland functions come more in the digestive chapter. Endocrine function is what we're going to be focusing on today. And so when we look at the exocrine part, we have these groups of cells called acinar cells, and so they'll cluster together, and those are going to be the cells that make those different enzymes for digestion. All right. Then when we get into the endocrine cells, we have our pancreatic islets, or the islets of Langerhans, as they're called. And so there's several different cells in these pancreatic islets. So there's 4, but there's only really 2 that I really care about. So you've got your beta cells, those are the most numerous, and those are the ones that create the insulin. And then you have the alpha cells, right, a little bit less numerous, and they make the glucagon. Keep in mind, what is the relationship between these 2 hormones here? Opposite. Yeah, they're antagonistic of each other. You nailed it. Yep. They're opposite. So, right, one increases blood sugar levels, the other one decreases blood sugar levels there. And then we have our delta cells that have our somatostatin, and then the F cells, which have a polypeptide secretion there. Again, I'm not going to really be concerned too much about that. All right, so here you can see, here is the spleen and the duodenum, and the pancreas sits right in between that. All right, so let's talk about the hormones that are responsible for blood sugar levels. This is a number that you should kind of familiarize yourself with, the normal range for blood glucose levels here. All right, 70 to 110 milliliters per deciliter. Right, and so one of the things that you have to understand is, and this is why diabetes is a disease of concern, especially in older people. Right? But one of the reasons why is, what is one of the symptoms for a person that's been diabetic for a long period of time, but really hasn't taken care of themselves too much? What would you say that they will complain about? Pain. What about their feet? What do they usually say about their feet? Yeah, neuropathy. Yeah, okay. So diabetes is horrible for your blood vessels and the nerves. And one of the problems is that long-term diabetes will mess up your blood vessels. And so a lot of times people with diabetes, okay, can and will have blood pressure problems. So now you're just adding insult to injury, because you already have the possibility of an individual having compromised blood vessels just from the diabetes for a long period of time. And then you're going to tell me that you're going to increase the pressure on the walls of those blood vessels. All right. And especially as we get older, you know, that things, I drive a very old car. It's almost 30 years old, but I love it. I will not get rid of it until the doors and wheels fall off. All right. But it doesn't drive as fast. It's not as resilient to the road conditions as it used to be. All right. The shocks and the struts don't work as well. Same thing with the blood vessels. They wear down over time. Your body repairs it a lot, but we have to be careful. And so that's why we have to worry about, all right, damage to the blood vessels, damage to the blood vessels in the kidneys, but also the kidneys themselves, the nephrons. That's the filtering mechanism, which we will discuss, right? No person, no normal, how do I say this? Healthy, I shouldn't say normal. No healthy individual should be excreting sugar in their urine, okay? Nobody. And when we go through the kidney process of what it does with glucose, how it will filter it and then resorb it, it's a very efficient system, but you're going to see that nobody should be getting rid of glucose in their urine. All right. Well, in this case, we have to be careful because glucose is a relatively big molecule. And so if it can slip through the filtering system, it can start to damage the filtering system. And that's what we have to be careful about. So if you look at all these symptoms here, I'm sure for any of you that have ever dealt with somebody that has had an issue with diabetes, the first one is tiredness. Right. And so, of course, when you have low levels, right, for your blood glucose, I get hypoglycemic, you know. That's why I always make sure that I go and eat before I go shopping with my family, because I'll be out shopping for about 4 to 6 hours and sometimes longer. Right. But tiredness, lethargy, big situation here. Mental and physical impairment, right? Weakness. I mean, if it gets bad enough, you could go into diabetic coma. All right. And then obviously, right, really low blood sugar levels can lead to death here. All right. So let's talk about insulin and its purpose. Right. Keep in mind, and I've said this before, insulin takes macromolecules, primarily glucose, and puts it into your tissues. Right, so keep that in mind. So always remember that. And so that means if we're going to put these macromolecules, if we're going to put glucose into the tissues, where are we taking it from? Yeah, from the blood. Yep, right up there. Lowering high blood glucose levels. That's what it's going to do. So it's got to take it from one place and put it in another. So when you get your blood drawn, right, and I'm sure a lot of us have looked at our blood levels there. Right. So when you get your blood drawn and you see on your blood report, like what your sodium levels are and what your glucose levels and all that stuff, it's only telling you what's in your blood. It's not telling you what's in your cells. Right. So for example, what did we say about potassium? Is there more potassium outside the cell or inside the cell? Inside, right? Remember, banana floating in the ocean. Okay. So there's more potassium inside the cells. So when I draw blood on you and I'm looking at your potassium levels, that's only telling me a small amount of the potassium. It's by design. It's supposed to be that way. You're only supposed to have a certain amount in circulation. Same thing with sodium. So kind of keep that in mind. When we're looking at this, we're only seeing how much glucose, all right, is going to be floating in your blood at that time. What we call postprandial, after you have a meal, all right, and the glucose starts to get released into your bloodstream. Right, so we'll discuss all this, but that's what we're seeing here, right? You just had a nice, delicious meal, let's say pizza, high in carbohydrates, all right? When I was in school, elementary school, no, maybe middle school, when they used to do the 4 food groups, there was only one food that actually had all 4 food groups in it, and that was pizza. And so they said, you got your bread. So it used to be breads, meats, vegetables, fruits, and dairy. So the bread was the crust, the dairy was the cheese, vegetables, whatever vegetables that you put on, fruits and vegetables was also going, fruits was tomatoes. Yeah. And then what am I missing? Oh, meat. Yeah. So whatever, if you decide to do pepperoni or whatever, but that's what they told us. All right. So you have a nice, delicious slice of pizza. All right. You start to digest it. And like I said, those beta cells here, right, they are going to detect that increase in your blood sugar levels, and they're going to immediately start to release insulin. And so insulin's going to go to work. It's going to start to take, all right, that glucose that's floating around in your blood, and it is going to then pull it into your tissues. And we'll talk about that. All right. So this slide here is telling us, all right, insulin is going to, oh yeah, we all love the butler, all right, the secondary messenger system. So it is going to utilize, all right, all of those various enzymes, cyclic AMP and all that fun stuff, right? And is going to utilize that secondary messenger system, right, to actually build and create what we call glucose transporters. Right? So you remember the story. Secondary messenger system utilizes, all right, several of the actual enzymes that reside in the plasma membrane, and they're going to create some sort of response. In this case, what will happen is it's going to stimulate your DNA to transcribe specialized mRNA molecules to build glucose transporters. What's a glucose transporter? It's a protein channel, right? Like a voltage-gated sodium channel and all that fun stuff. And we're going to build a whole bunch of them. And guess where we're going to put them? We're going to start jamming them into the plasma membrane. So maybe you have 5, no, you never will, but if you say you have 5 glucose transporters in the plasma membrane before the insulin was released, afterwards, you could have up to 200 or whatever. You'll have a large amount. So now you have all these glucose transporters that can then pull glucose into the cell. And that's what we're going to see here, all right? All right, so let's look at some of the cells and tissues that are going to respond to the effects of insulin. All right, so up until this point, remember all our hormones that we talked about, when they affect the liver cells, they're going to increase glucose or nutrient levels in the blood. Not insulin. Insulin now does the opposite. So here's what's going to happen. Insulin is going to strike out glycogenolysis. It's going to stop liberating glucose from the glycogen molecule. It's going to stop gluconeogenesis, but guess what? It's going to kick in glycogenesis. Start pulling glucose from the blood and sticking it together into that glycogen molecule and storing it away in the hepatocytes. Boom, easy, easy. Adipose cells, same type of scenario. Remember, insulin puts stuff or the macromolecules into things. So we're going to now take all of those fatty acids, okay, that are floating around, because you'll get fatty acids from digestion, right? Especially if you've eaten something that has a lot of protein in it, right? So we're going to start digesting down those molecules. Same type of situation. We're going to inhibit lipolysis. We're going to stop making fat, and we're going to start, did I say stop making fat? We're going to stop liberating triglycerides, and we're going to make fat. We're going to store, right, all those triglycerides into our adipose sites for a rainy day or for whatever. That's also going to decrease your blood levels of fatty acids, because we're pulling it out of the blood and storing it in the adipocytes there. Right? And so pretty much all of these cells here in your body are going to start then taking up a lot of those macromolecules there, right? And either using the glucose for whatever. In some cases, we're going to store, maybe your skeletal muscle cells need to replenish. Remember the oxygen debt that you learned about in 210, right? Maybe we're going to restore that oxygen debt to some of those tissues and restore the glycogen levels to where they were before in your skeletal muscle here, right? So we're going to see, remember, can't stress this enough, and I don't care, I'll say it 100 million times, right? Glucose is going to increase the uptake of those macromolecules into your tissues there, right? So we'll see protein synthesis. There was I don't even know if they still do this, because I don't really follow bodybuilding all that much, but there was a period of time when professional bodybuilders, right, when they didn't want to use steroids or growth hormone, they were using insulin. Not the best idea, all right, but they were using insulin for that reason there, going back to protein synthesis there, to make up, all right, that actin and myosin for those cross bridges for their muscle mass there. I don't agree with it, but that's what happens. All right. Whole purpose of insulin is to increase that glucose transport across the plasma membrane by inserting those plasma channels. Did I say plasma? Those protein channels, right? Those, what we call the glucose transporters, right? Because glucose is a relatively large molecule and it cannot diffuse directly through the plasma membrane, so it needs help. right? And so it's going to utilize those glucose transporters to do so there. All right, interesting fact here at the bottom, some cells do not need insulin. And if you look at all of those cells are relatively important cells. The first one up there, neurons, right? Insulin doesn't affect them, okay? And remember what I told you, I think it was last class, that 2/3 of your total energy expenditure for a neuron is just operating those sodium potassium ion pumps constantly. That's all they do all day long, 24/7. And so we don't have time, if you think about it, we can't waste time on trying to synthesize and make these glucose transporters there, right? So insulin has no effect. So they're going to be maximizing and trying to get as much of the glucose, right, into the cells. And if you look at the list of cells here, kidney cells, hepatocytes, and red blood cells, all very, very important types of cells when we're looking into the effects of glucose here. So here's a real simple picture. Zoom in here. All right, so here we are. Here is insulin dealing with the pancreas. There's our stimulus, increased blood glucose levels. Boom, you have a glucose-rich meal, okay, that piece of pizza. The beta cells have the receptors there that monitor that increase in blood glucose, and they are stimulated now to release insulin into your bloodstream. And so the insulin then will travel around all the way to the effectors. And so basically what we're going to see here is when we're looking at these tissues here, liver is going to take all those glucose monomers and start to make glycogen with them. So it's going to increase, right, glycogenesis, decrease gluconeogenesis, and glycogenolysis. Same thing here in the adipose tissue. We're going to make more adipose tissue. So we're going to increase lipogenesis and decrease lipolysis there. And then all your cells are going to increase, all right, especially amino acids, specifically for protein synthesis here, right? And then also we'll see if we need to, all right, proteins are going to help us to make more channels to get more glucose. So kind of keep that in mind when we're looking at glucose, especially in this chapter. I want you to have a nice appreciation for insulin. So you can kind of see up to this point, we have not talked about another hormone that does anything that that insulin does, right? Everything else seems to do the opposite. Everything else so far, is going to increase blood sugar levels. Insulin is the only one that decreases it so far that we talked about. All right, let's talk about diabetes mellitus. This is a condition, a phenomena. I listen to news programs all the time that talk about health statistics. I don't even know where we are now, but they are saying that diabetes is an ever increasing condition, and what should be the most alarming aspect to that is it's an ever increasing condition in children. Right? And so that's huge because long-term diabetes, we've seen the condition. I mean, the number one cause for amputations in the United States is diabetes mellitus, losing toes, losing feet, right? And so why? I just talked about it. What does decreased insulin do? People with diabetes damages blood vessels. You damage blood vessels, you decrease blood flow, you can cause tissue damage. Go ahead.
Alzheimer's, I think maybe schizophrenia is technically like diabetes 3 or something.
That's so funny you said that. I either heard that on a podcast or I read that somewhere last week that it is considered to be, and it was Alzheimer's. I didn't hear about the schizophrenia, but the Alzheimer's was considered to be the diabetes 3. It's very, very interesting that you bring that up. Yeah. Yeah. And again, I mean, I could go on and on. My best friend's schizophrenic and I could tell you stories. He doesn't mind me telling you stories, but especially with Alzheimer's, and it goes back and forth with what we're discovering with Alzheimer's. Some of the popular theories were that it was the tau tangles, which is a protein, neurofibrillary tangles. You get these protein deposits in the neurons that would cause. They're kind of moving away from that. We're still learning, but yeah, I mean, it's one of those things in which we're seeing an increase in diabetes. We're seeing an increase in Alzheimer's. I don't know about schizophrenia, if there's, yeah, no, but I mean, yeah. But the point being is these things are increasing, and that's something that we have to be aware of. And so anyways, when we look at diabetes mellitus here, definitely know the definition here, all right? Real easy, okay? We cannot take up the glucose that's in your blood. And this one right here, I'll say it again, right? You have elevated blood glucose levels, you're increasing significantly your risk of damage to the blood vessels, especially the blood vessels here in the brain, stroke, right? That's something you have to be very, very concerned about when you're dealing with these patients here. The number one, all these cool statistics here, the number one cause of blindness, all right, diabetes, retinal blindness, because, all right, it affects blood vessels, and there's tiny blood vessels. Y'all remember from when you were studying chapter 16 and we learned about the eye, all those blood vessels that you saw in the retina there, okay? So those are the ones that usually get affected first because they're so small. Okay, so one more thing this is almost like a PSA. Be very concerned too, folks with diabetes, for it increases significantly their risk for stroke and for heart attack. And problem is, there's a class of drugs out there, and again, I haven't seen anything too much, so it's not 100%. That's still in what I consider it to be in the theoretical basis, but beta blockers, very common class of drugs that are used to treat heart issues, but primarily blood pressure. All right, but they found, or there's some evidence that beta blockers can affect insulin production in the pancreas. Again, it's not 100%, depends on who you talk to, all right? But there is literature that's out there, I'm just saying. Okay, so type 1 diabetes. This is the one in which kids, all right? That's the one that you'll see with a kid that is on insulin, all right? Because their pancreas is not producing insulin. Type 2 is the one that you hear that's adult onsets, and that's the one that you hear more so in older folks here. So keep in mind, all right, your pancreas can have a little bit of insulin being produced, but the amount of insulin is pretty much useless and it doesn't have any physiological effects. So usually we say there's no insulin production in folks with this. So you'll see it in a younger population there, right? And so this is the one in which they have to have a protein pump, an insulin pump. Okay, so this patient, way before these awesome insulin pumps that we had now, this was the kid that usually had to give themselves a jab of insulin every, usually around mealtime and whatnot. They were sticking their fingers to monitor their blood glucose levels. With the insulin pump, it's way easier. It's much better now. Some of those newer pumps are amazing, especially with Bluetooth. It goes right to your phone. I mean, it monitors the blood sugar levels and then it can release. I mean, it's much easier. And so I'm very, very grateful, especially for parents of these kids, because I can only imagine having to be up for several hours in the middle of the night when you're worried about your kid's going to, go into coma, into diabetic coma. All right. Anyways, type 2. This is the one that we're seeing the incidence on this type of diabetes is increasing significantly. And so, of course, we have to be very, very concerned about this. A lot of doctors believe that this is the one that can be avoided, all right? And there's a lot of conditions that can be avoided, all right, if we just took better care of ourselves. But the big thing that folks will say to avoid type 2 diabetes is through diet and exercise. Just be a little bit more active, okay? Challenge yourself, challenge your body, right? And so that's some of the ways that you can treat type 2. Now, type 2 diabetics can release insulin, but their cells, you'll hear them, some folks say there's a resistance to them. But the receptors on the cells, all right, are one, in some cases on the target cells aren't enough, right? Or it's just not having the desired effect there, right? But keep that in mind, right? The effectiveness of insulin has reduced somewhat, and it could be a couple different reasons, but usually it has to do with the effects of insulin reacting with the target cell receptors there, okay? And so again, some of the characteristics: older adults, right? And one of the big causes that they are saying right now for type 2 diabetes is obesity. Gestational diabetes is always an interesting one. This was the one, my mother, I'm the youngest of three. It's a good thing that I was the third child. I was almost 12 pounds when I was born. I know. And yes, it was a vaginal delivery. It wasn't a C-section, which is crazy. I know. My poor mother. But they thought gestational diabetes, and they thought that it was as big as I was because of what they never confirmed it. I'm almost positive that she had gestational diabetes. So this was a long time ago. I don't think I was late. You know what? I think, in fact, I might have been early because I think my birthday was supposed to be a week later. But yeah, it was, yeah. But anyways, one of the things that you have to look at is this last fact down here: increases the chance of later developing type 2 diabetes. And what they should also, and I should have added this in here, that goes for both mom and baby. Okay, so the baby also has an increased chance of having type 2 diabetes. So just something to consider. But gestational diabetes, you're only going to see that in one population of people, pregnant women. Okay. All right. Very important term listed up here: hypoglycemia. Hypo means decrease, glycemia. Remember, any word that has emia has to do with the blood. Okay, so this is talking about your blood glucose levels. So what's the normal range? Y'all remember for blood glucose? Yes, perfect. All right. So if you fall below 60 here, right, then you will be hypoglycemic. And some of the symptoms here that folks will have, all right, obviously, I can attest to this, definitely hunger, some lethargy, some tiredness there. And for whatever reason, this is definitely true: sweating. You just start to get those cold sweats there. Very, very uncomfortable, right? So easy. How to treat this? Give somebody some sugar, all right? Give somebody, all right, some candy, whatever it is, right? But that's, pardon?
If they can swallow it.
Yeah, swallow it?
If they can swallow.
Yeah. How about juice? Yeah. I know some folks that will carry like those small like Gatorades around with them just in case to help with that. But anyways, so if you notice here, look what some of the things that can cause. I mean, this makes complete sense, right? Insulin overdose. You take too much insulin, it's going to drop your blood sugar levels down. Right? So that should be a no-brainer there. All right. Prolonged exercise. What are you going to do when you're exercising? You need energy. Where are you going to get it from? You burn it up through whatever the tissue on hand has, you're going to go to the bloodstream next. And so if you burn through that, you're going to get hypoglycemia. So a lot of this stuff should make sense to you here, and so forth and so on. But again, what we want to do is give somebody some sugar here. And this, I don't know your name. Christian. Okay. Christian, you know this by heart, I mean, glucagon, aren't you guys always carrying that? And then what's the other injectable that you guys carry on board? Is it, if you have, so there's two things I was told. My buddy used to be a paramedic up in New York, that if you come across an unconscious person, you have the option of either giving glucagon, that's what he told me, or what's the other one? Okay, and that's the treat. Yeah. And then what about, though, for heroin overdose? Narcan. That's what I was told. That's what he said. They always carried those two things. Yeah. Yeah. Right. Yeah. Yeah. That's what he said. And so I stand by it. Okay. So let's now switch gears and talk about our buddy glucagon, the antagonist of insulin, or one of the antagonists of insulin, but this is pretty much a direct antagonist of insulin. All right. So know the cells that produce it, the alpha cells there. All right. Same type of scenario that we're going to see. Blood sugar levels have now decreased, low blood sugar levels. So, all right, near the lower part of the range there, 70, all right, milliliters there, or below, we're going to start to see right? As increase in secretion of glucagon from the alpha cells there. And so we're dealing, I hate to say it again, there's those secondary messengers again. So very similar that we ran into with insulin, secondary messenger system, same type of scenario here. Again, in this case now, we're going to increase nutrients in the blood. So we should know how to do that by now. Do y'all feel pretty comfortable with that? Which processes, I should say. All right. So go back to what we learned earlier on in this chapter. All right. If we want to increase nutrient levels in the blood, we're going to stimulate glycogenolysis and gluconeogenesis there. And so same thing here. We're going to decrease glycogenesis because we don't need to make the glycogen. We need to break it down and release it so we can increase our blood sugar levels there. And then go to the adipose tissue, same thing. We need our fatty acids and our glycerol. Why? Because we can use those to make glucose through gluconeogenesis. So how are we going to do it? We're going to stimulate lipolysis. And we're going to say, to heck with lipogenesis. We're going to inhibit that. Right? One of the things, though, that you want to know is this right here. Glucagon does not affect protein composition. It's not going to mess around with protein catabolism, right, or anabolism or any of that. It is not going to stimulate amino acid levels one way or another. All right, so that's important to know that difference, because up to this point, we've seen some of those situations, all right, when we talk about cortisol, we saw how it affected protein metabolism there, all right? There you go, Christian, right here, paramedics, unconscious, all right? So glucagon. All right. So here we're looking at our here is our reflex there, right? So you'll see the stimulus, right? We have decreased blood glucose levels, right? Alpha cells detect that, release the glucagon. Glucagon goes into our bloodstream. It's going to stimulate the release of glucose from the liver through gluconeogenesis, glycogenolysis, and then we're going to increase the release of fatty acids and glycerol from the adipose tissues there, right? Through lipolysis and decreasing lipogenesis. Pretty good. I feel like I'm repeating myself a lot.
Those words like lost me.
Almost. I say it so many times. I know. I just want to make sure I say the right words. So that's why I have to double check myself. All right. And so the same thing here. We're going to be dealing with that negative feedback loop. So when blood sugar levels get up to a significant level there, then we're going to then stop the production of glucagon. Oh, perfect. I'm going to stop right here. This is perfect. I want to talk more, but we'll give the pineal gland a break